The next session will be workshop 12, surgery and transplantation, TACE, HAIC, and vascular interventions. This session will be chaired by Dr. Darrell Crawford, Dr. Michie Sakamoto, Dr. Shinji Tanaka, Dr. Michiaki Unno. Doctors, please.
Okay, good morning, everyone. We would like to start workshop 12, surgery, transplantation, TACE, HAIC, and vascular interventions. This session will be chaired by Professor Michiaki Unno and Professor Shinji Tanaka, and myself from Japan, Michie Sakamoto. And unfortunately today, Professor Darrell Crawford from Australia cannot join. So we have 5 speakers in total, and the first two sessions will be chaired by myself, the next 2 sessions by Professor Tanaka, and the last one from Professor Unno. So we'd like to start the first presentation. The first speaker is Dr. Yusuke Nishi from Ehime University, and he will talk about the impact of local ablation in resected hepatocellular carcinoma. Dr. Nishi, please.
Thank you for Chairperson. Today, I'd like to discuss the impact of post-local ablation therapy on liver resection. We have no COI to disclose regarding this presentation. HCC is often treated with non-surgical resection, such as local ablation, at the time of initial diagnosis. However, the cumulative recurrence rate at 5 years after LA therapy is 72%. The impact of LA on the subsequent hepatic resection course of treatment is not clear. My purpose today is to present the effect of previous LA on histopathological findings and prognosis in patients undergoing their hepatic resection for HCC. This slide describes the eligible patients. We studied hepatocellular carcinoma patients who underwent hepatectomy at Ehime University Hospital from October 2003 to July 2021. The initial group consisted of 194 patients who underwent hepatic resection for previously untreated HCC. On the other hand, 38 patients in the local ablation group underwent liver resection due to recurrence or inadequate ablation. We excluded cases in which the time from local ablation to surgery was more than 3 years because of the possibility of multicentric calciogenesis. We compared patient background, perioperative factors, histopathologic findings, and prognosis between the 2 groups. In this slide, I would like to show the details of the local ablation group. About 80% of the patients underwent TACE at the same time. There was a history of local ablation to the targeted recurrent site at the time of liver resection. The time between the last previous treatment and surgery was less than 1 year, and the median number of treatment was 3. This slide shows the patient background for this study. The local ablation group has significantly more hepatitis C, smaller tumor size, more multiple tumors, and more portal vein and serosal invasion. There was no differences in perioperative factors between the 2 groups. This figure shows overall survival from initial treatment, overall survival after hepatic resection, and RFS after hepatic resection, respectively. There was no significant difference in overall survival either after initial treatment or after liver resection. RFS after liver resection was significantly shorter in the low collaboration group. This slide shows the result of the analysis of risk factors for RFS. Univariate analysis shows significant differences in PBCA2 greater than 40, history of low collaboration, tumor size greater than 3 centimeters, multiple tumors, and positive portal vein, hepatic vein, and serosal invasion. In multivariate analysis, low collaboration history, tumor size greater than 3 centimeters, multiple tumors, and positive serosal invasion remain, and low collaboration history was an independent risk factor for RFS. This slide shows the results of the analysis of risk factors for positive serosal invasion. Multivariate analysis showed that a history of low collaboration was an independent risk factor for positive serosal invasion. Additional analysis also examined risk factors for positive vascular invasion. These analyses reveal that tumor markers and history of low collaboration were independent risk factors for positive vascular invasion. Now, I'm going to go on to the discussion. Orimo T. et al. Reported that postoperative survival and cumulative recurrence rates were comparable between the liver resection group for intrahepatic recurrence after RFA and or TACE, and the liver resection group without preoperative treatment. In the present study, a history of LA was an independent risk factor for RFS after liver resection. The study also shows that a history of LA was an independent risk factor for pathologic serosal invasion and vascular invasion. Hepatocellular carcinoma is known to metastasize intrahepatically via the transporter vein, and anatomic hepatic resection is recommended. Therefore, based on the results of this study, we hypothesize that anatomical liver resection in patients with a history of low collaboration will contribute to improved prognosis. This figure shows OS with and without anatomical liver resection in the low collaboration group with no significant difference. So surgical procedure did not show the superiority for prognosis of previous LA patients in these studies. This study has several limitations. First, it is a retrospective study. There is a small number of cases and possible lack of power. Furthermore, this study compares a no prior treatment group with the LA group, and bias may exist because the no prior treatment group includes cases for which RFA was not indicated, while the LA group selected cases for which surgical resection was feasible possible after recurrence. This is the last slide. We found that patients with HCC previously treated with LA have a risk of invasion tendency and postoperative recurrence. Thank you for your attention.
Thank you very much, Dr. Nishi, for your excellent presentation. So, do you have any question or comments from the audience or from the web, maybe? So, I think this study is very interesting, and I feel I worry very little manuscript reporting this kind of data, I'm afraid. So, how about the site of serosal invasion? Is it just on the route of the penetration?
In this study, we do not consider that site of serosal invasion. So I will try to next steps.
But you identified the serosal invasion on pathological specimen, resected pathological specimen. So maybe you can identify if it is on the route of penetration or not, maybe histologically.
In all cases, RFA routes is not unclear. So, but I think penetration area is will become serosal invasion site.
Because we have so many discussions about dissemination after liver biopsy, but very few discussion after this kind of local ablation. But the, how anatomically they may be quite similar, I think. So I'm so curious about it. So. And how about the presence of peritoneal metastasis in those cases, or peritoneal recurrence?
Peritoneal, in our studies, peritoneal recurrence is very low, few cases, 3 or 4 cases. So we can better analyze, we can't analyze this.
But it is also very interesting. And then it means the serosal invasion does not directly cause patient survival, maybe. How about it? So you showed the data of recurrence, but not about the survival. So is there any difference for survival, overall survival?
Almost cases, recurrent site is liver, about 95%. Yeah. Some cases have lymph nodes or liver, lung or peritoneal. So it is difficult to clarify the survival rate beyond, up to recurrent site.
Okay. So any question from the chairs or, yeah, please.
Beyond the anatomical mechanism, potentially molecular mechanism might be contribute this recurrence. For example, EMT or hypoxic stress or oxidative stress induced by the local ablation. Did you check that there are any comments on this molecular mechanism?
Thank you. Some factors relate recurrence, serosal invasion or portal vein invasion. One is intrahepatic portal metastasis or penetration recurrence, or heat shock, or maybe.
Thank you.
Any other question or comments? If not, thank you very much, Dr. Nishi.
Thank you.
Then we would like to move to the second presentation. It will be the title of his talk is Ferroptosis is induced by lenvatinib through fibroblast growth factor receptor 4 inhibition and play a key role in the suppression of hepatocellular carcinoma. So presented by Dr. Norifumi Iseda from Kyushu University. So Dr. Iseda, please.
Thank you so much for having me today. I'm Norifumi Iseda from Department of Surgery and the Science Graduate School of Medical Science, Kyushu University. Today, I would like to talk about ferroptosis induced by lenvatinib through fibroblast growth factor receptor 4 inhibition and play a key role in the suppression of the hepatocellular carcinoma. We have no COI. I'll explain about ferrotosis. Ferrotosis is caused by the accumulation of lipid peroxidase in cell membrane in an iron-dependent manner. Elastin inhibits systemicity, suppresses glutathione peroxidase 4, and enhances ferrotosis. Ferrocystin 1, FER1, is an active radical scavenging antioxidant that scavenges lipid peroxidase and inhibits ferrotosis.
あ、はい、多分ポスターに入って
Lembatin suppress RET, VEGFR, and FGFR, inhibit tumor cell proliferation, survival, and angiogenesis.
多分、発表に、プログラムに
NAF2 is a transcription factor that plays a central role in intracellular redox regulation, is involved in tumor invasion ability and resistant to chemotherapy, and has been reported to be a factor in prognosis. It has been reported
そう
that
ですね。メールが
NAF2
初めて
translocates into the nucleus upon stimulation, such as oxidant stress,
そうですね
affects the production of GSH,
なんか
NADPH,
あれ違いますね。
and activates
と、
antioxidant
あ
and
で、
detoxification metabolism.
その、ここに入ってないからね。
そうです
はい、はい、そう、ここに
います。
The aim of this study was to identify cell deaths associated with lenvatinib in HCC and the role of NAF2. Methods. Lenvatinib, the ferrotosis-induced drug elastin, and the ferrotosis inhibitor FER1 were administered to HCC cell line, and lipid peroxide and cell viability were measured. Next, we knock down FGFR4, the target of lenvatinib in HCC cell line, and measure the expression of ferrotosis-related protein, lipid peroxides, and cell viability. To create HCC cell line with high NAF2 expression and low NAF2 expression, and to examine the effect of lenvatinib. And we performed immunohistorical staining of FGFR4 on liver dissection specimen for HCC and compared the effect with lenvatinib. HUH7 and HEP3B HCC cell line, lenvatinib decrease the expression of systemic CT and GPX4 in HUH7 and HEP3B. These figures show the level of lipid peroxidase. Lenvatinib increased lipid peroxidase, this one, and FER1 suppressed the lipid peroxidase production in HUH7 and HEP3B. Elastin, which is ferrotosis-induced drug, elastin increased lipid peroxidase similarly. FER1 suppressed lipid peroxidase production. These figures show the cell viability. Lenvatinib decreases the cell viability, and the cell survival rate increased when FER1 was administered. Similarly, elastin decreased cell viability, but the cell survival rate increased when FER1 was administered. Brief summary. Lenvatinib to HCC cell line decreased the expression of ferrotosis-related protein. HCC cell line with lenvatinib and elastin, lipid peroxidase was produced, and the decrease in cell survival rate was observed. Simultaneous FER1 suppressed the production of lipid peroxidase and suppressed the decline in cell viability. This slide shows the Western blot results. Knockdown FGFR4 decrease the protein expression of systemic CT and GPX4. Knockdown of FGFR4 increase the lipid peroxidase level, and the FER1 suppress the lipid peroxidase production. Knockdown of FGFR4 decrease cell viability, but FEL1 did not decrease cell viability. Brief summary. Knocking down FGFR4 in HCC cell line suppresses the excretion of ferroptosis-related protein, lipid peroxidase production, and decrease cell viability. Next, in NAF2 overexpression HCC cell line, lipid peroxidase production was suppressed with lenvatinib compared to MOC. In the NAF2 overexpression HCC cell line, cell viability was higher with lenvatinib compared to MOC. Next, NAF2 knockdown HCC cell line, lipid peroxidase was higher with lenvatinib compared to control. In the NAF2 knockdown HCC cell line, cell viability was lower with lenvatinib compared to control. Brief summary. In HCC cell line with high NAF2 expression, lenvatinib suppressed lipid peroxidase production and increased cell viability rate compared to MOC. In HCC cell line with low NAF2 expression, lenvatinib increased lipid peroxidase production and lowered cell survival rate compared to MOC. Next, we investigated the correlation between lenvatinib and FGFR4 expression. The patient with positive FGFR4, this one blue line expression in cancer cell had significantly longer progression-free survival than those of negative FGFR4 expression. Discussion. Sorafenib induced ferroptosis through ferrostatin heavy chain 1 in HCC. NAF2 binding to the systemic CD promoter and is involved in systemic CD expression in breast cancer and glioma. Synergistic effects of drug therapy and NAF2 inhibition are expected in HCC. Conclusion. Lenvatinib suppressed FGFR4 and induced ferroptosis. NAF2 avoided ferroptosis by suppressing lipid peroxidase caused by lenvatinib. Thank you.
Okay. Thank you very much, Dr. Iseda, for your nice presentation. So, any questions or comments from the audience or on the web? I think you showed so many data for a short time. So,
Thank you.
But I think you clearly indicated a very good, strong correlation between FGFR4 expression and ferroptosis, and also involvement of NRF2 in the process. I think it's very interesting. And also you showed human data that FGFR4 is strongly associated with the effect of lenvatinib. So I wonder if FGFR4 is so the in vitro data is very clear and very significant, but I worry if the total story applies on human samples or surgical specimens, because how to say, such kind of ferroptosis condition may be quite different in the microenvironment. Culture condition or human organ environment may be more complicated. And in case of human samples, I think the ligand of FGFR4 is also very important. For example, FGF19 dependent proliferation could be another mechanism of, how to say, cell tumor proliferation, not only suppressing ferroptosis, I think. How do you think about it?
Yeah, thank you. In cell line, cell death caused by lenvatinib was almost ferrotosis, but VEGF is very important. But VEGF is poorly expressed in cell line. So the cell death of rheumatism is dependent on FGFR4 suppression in cell line. In human, suppression of VEGF is very important. So therefore, in vivo experiments are very, very necessary. But we have not been done yet. Next, I think I would like to consider this point in the future.
Yeah, very complicated, but very interesting. So please.
Yeah, thank you very much for your interesting presentation. I think you talked about the importance of ferrotosis induced by lenvatinib in ACC. Then you showed the clinical data. Then I thought the expression of FGF receptor 4 was seen in the half of the patient with ACC in clinical situation. Is that right?
Yeah, right. Inside.
Oh. So I thought it's really high. Is there any difference from your data and other literature in the expression of FGF receptor 4?
Yeah, I use method of FGFR4 expression. The positive FGFR4% was 10%.
10%.
Yeah.
Oh, really? Oh.
Yeah, positive FGFR4, yeah, 10%.
So only 10% patients showed.
Sorry, half of patient. Yeah, but
So 10% means 10% of tumor cells.
yeah, tumor cells.
Okay.
Sorry.
Positivity is
Positivity.
Okay.
Yeah.
And you only show the progression-free survival, right? Then do you have any difference in the therapeutic response assessed by mRECIST or RECIST at that?
RECIST.
RECIST or
yeah.
mRECIST. Do you have any difference in the expression of FGF receptor 4 in clinical patients?
RECIST and mRECIST between
between no expression of FGF receptor 4 and expressed FGF receptor 4 group.
Yeah, positive FGFR4 patient had a good clinical case, PR or SD, CR.
Thank you very much.
As pointed, frequency of FGFR4 positive HCC is maybe very interesting or very curious. Yeah, maybe more hepatitis B than maybe more positive cases, I'm afraid. No? Etiology. difference.
Etiology.
Maybe may associate, may affect the instance.
Etiology is not, yeah.
Okay. So yes, please.
Short question. Also from Kurume University, Koga, Dr. Koga. Are you planning to treat the cell with lenvatinib combined with the XCT inhibitor, such as salazopidine?
Salazopidine. Systemic XCT
inhibitor.
We did not use.
Are you planning? Are you planning?
Thank you.
How about your data, Dr. Koga? You have some data?
No,
Not yet?
But I previously experienced with the XCT inhibitor in terms of the cancer stem cell story.
Okay, thank you very much. Any other questions? If not, thank you. Thank you, Dr. Iseda.
Thank you.
Okay, next speaker is Dr. Naoki Hashimoto from Asanda City Hospital. The title is Hyperuricemia after hepatic resection. Please
Thank
start.
Thank you. I will make a presentation, hyperamyloidemia after hepatic resection. With the increased experience in hepatic resection, it has been noticed that hyperamyloidemia occurs post-operative although the most patients with hyperamyloidemia following hepatic rejection have few clinical symptoms. Some patients develop pancreatitis, leading to fatal complication. The mechanism of postoperative hyperamyloidemia is not clear. The aim of this study was to analyze factors that may be associated with the development of hyperamyloidemia following hepatic rejection. 23 patients underwent hepatic rejection for primary or secondary liver tumor, Pringu 12 case, hemihepatic 11, intermittent clamping of hepatoduodenal ligament by Fogarty clamp 15 minutes and reperfusion 5 minutes. Dissecting of relevant lobular afferent vessel as the hepatic hilum and intermittent occlusion of these vessels by bulldog clamp 30 minutes and reperfusion 5 minutes. Creatine, total bilirubin, albumin, and ICG-R retention 15 times were measured preoperatively, and operative blood loss and operative time were examined postoperative. Serum amylase and creatine level were measured on the preoperative day and postoperative 1, 2, 4, 7, 10, and 14 days. Pringu group and hemihepatic group age same. Total bilirubin hemihepatic group slightly higher compared to Pringu, and albumin level hemihepatic group lower compared to Pringu group. ICG-R retention 50 minutes percent, Pringu group 2.63 plus minus 1.35, and hemihepatic group 10.8 plus minus 1.5, no difference. Operative time, Pringu group 3 hours and 30 plus minus 30 minutes, but the hemihepatic group 467 plus minus 60 times, much longer compared to Pringu group. Operative blood loss, hemihepatic group much higher, much larger compared to serum amyloid level, Pringu group and hemihepatic group. Pringu group postoperative 1 to gradually increase and thereafter gradually decrease. Hemihepatic group from pre and post operative 40 days, there is no difference. But the Pringu group 1, 2, 4, 7, 10 days, serum amyloid level much higher compared to hemihepatic group. Serum creatine level, hemihepatic group, Pringu group from preoperative and postoperative 14 days, no difference. Renal function should also be considered when evaluating the serum amyloid level, because impaired renal handling of amyloid may result in high serum amyloid activity without pancreatic cellular damage. All of the patients in the present study had well compensated liver function without assist, and they had normal BUN creatine level, pre and postoperative. These data indicated that renal function did not deteriorate postoperatively, and the elevation of serum amyloid implies the pancreatic damage induced by prolongation portal congestion. Conclusion, it is suggested that portal congestion by portal triad interruption carries the potential risk of serum amyloid elevation and pancreatitis after hepatectomy. Thank you.
Thank you for interesting data on the clinical maneuver, Pringu maneuvers. Is there any questions or comments from our website? Okay. Is there any, how did you choose this hemi clamping or Pringle maneuver?
Yes, yes. Pringle maneuver, total portal clamp,
Yeah.
hepatic right or left clamp. Therefore, the total in case of Pringle group, pancreas and small intestine area congestion.
Mhm,
Therefore, sometimes we have cases of pancreatitis in Pringle group, high amylase level in Pringle group.
Yeah, I agree that. But how did did you choose this the method?
Pringle group
Yeah,
and Pringle group. Relatively liver function good case in Pringle and not so good group hemihepatic clamp.
Again, so the operation time is longer.
Yes, Pringle group is a short time compared to hemihepatic group, slightly bleeding. It is from my impression, bleeding control is difficult compared to the total Pringle group.
That clamping time might affect this elevation of the amylase, serum amylase. Did you check that clamping, the difference with clamping time?
30 minutes and
but how many
30
times
minutes and reperfusion 5 or 10 minutes. Repeat.
Yeah, total clamping time is different. Is there any difference?
Total clamp time slightly hemihepatic group longer.
Oh, yeah.
Thank you for excellent talk. And then, do you check on a subtype of amylase? Subtype. Amylase has two subtypes, and salivary gland
yes,
type and
yes,
a pancreas type. Do you check on
salivary amylase and pancreatic amylase? That's the we don't check the amylase isoenzyme. Salivary not check. But from impression and other authors paper sometimes pancreatitis and high amylase level. Therefore, you say that I check the salivary and pancreatic amylase, which is much larger. Is I think consider is better.
Yeah, I know, but a long operation make high amylase because of salivary types, because of the intubation, and then so I think you check subtype group. Thank you.
Okay, is there any comments? Okay, thank you for your great presentation. The next speaker is Dr. Hideki Iwamoto from Division of Gastroenterology, Kurume University. Dr. Iwamoto, please start.
Thank you very much for giving me the opportunity to present our work. Today, I am talking about the effectiveness of the local regional treatment using hepatic arterial infusion chemotherapy. The regimen is NUFP for locally progressed HCC. I have no financial relationships to disclose. Now we are in the era of chemodiversity in the treatment of advanced HCC. Now we have 7 approved drugs. The sorafenib was from the 2009. Now we have 7 drugs. Then what's happened in the era of chemodiversity? Now it's a sequential drug therapy is becoming mainstream. Accumulation of progression-free survival due to each drug is important in the era of chemodiversity. But is sequential drug therapy enough to treat all type of SCCs? For example, huge SCC and SCC with macrovascular invasion, because we have many local regional treatment options, modalities. In our facility, we have powerful local regional treatment. It's called NUFP. It's one of the HAIC regimen. NUFP has been developed by Dr. Hiroaki Nagamatsu in Juntendo University. NUFP is a regimen using a fine powder cisplatin, it's called the IA-COL, suspended with ripiodol, followed by administration of 5-FU. In detail, we firstly inject the 50 milligram of cisplatin suspended with ripiodol under angiography. After that, 250 milligram bolus injection of 5-FU and 1,250 milligram continuous injection of 5-FU for 3 days. The purpose of this study is to find appropriate tumor condition that can achieve the benefits of local region treatment using hepatic arterial infusion chemotherapy, especially NUFP. The method 1, we retrospectively correlated the NUFP data from 10 facilities that performed the NUFP and the sorafenib data from 10 facilities that did not perform NUFP. Then we collected 1,709 data and excluded child-pure class B or C cases and incomplete data. After that, we performed the propensity score matching. Then we compared the therapeutic effects between NUFP and sorafenib. The number of patients was 198 in each group. We compared the overall survival and assessed prognostic factors. Here I show the patient characteristics. Before matching, there was a significant difference in the etiology and the tumor size and the presence of macrovascular invasion and the presence of extrahepatic spread and the DCP level. But after propensity score matching, there was no significant difference between the two groups. Here I show the overall survival in the whole patients. Before propensity score matching, the MSD of NUFP was 17 months, and that of sorafenib was 12 months. There was a significant difference. NUFP was superior to sorafenib. After propensity score matching, the MSD of NUFP was 18 months, and that of sorafenib was 9 months. So NUFP was superior to sorafenib. The hazard ratio was 0.54. Then here I show the prognostic analysis in overall data after propensity score matching. We performed the univariate and the multivariate analysis. Then the multivariate analysis showed the presence of major PVT and the presence of extrahepatic spread was poor prognostic factors, and child-pure score 5 and choosing NUFP was better prognostic factors. Then next, I show the next assessment, method 2. Moreover, we have conducted subgroup analysis that were categorized by the presence of macrovascular invasion and extrahepatic spread. So we set 4 cohorts, MVI minus and MVI double positive. And after propensity score matching, we compare the overall survival. Here I show the the survival analysis in cohort 1. Cohort 1 is MVI minus and extrahepatic spread minus. The MSD of NUFP was 20 months and that of sorafenib was 17 months. There was no significant difference between the two groups. In cohort 2, cohort 2 is the MVI posi and extrahepatic spread minus. The MSD of NUFP was 19 months and that of sorafenib was 8 months. There was a significant difference between the two groups. NUFP was superior to sorafenib. Then in cohort 3 was MVI minus and EHS positive. This cohort 3 was not evaluable because of low number of patients, because usually NUFP performed the hepatic region progressed cases. And cohort 4, the MVI posi and extrahepatic spread posi. The MSD, basic MSD is really short. The sorafenib was only 4 months and that of NUFP was 8.8 months. There was a significant difference and NUFP was superior to sorafenib. Hazard ratio was 0.5. Here I show the representative case treated with NUFP. This patient had 3 independent portal vein tumor thrombus, P3, P4, and P5, and 1 major PVTT in right first branch. We administered the NUFP therapy. Then all tumors disappeared by NUFP. He survived more than 4 years. Case 2 is the NUFP for HCC with invasion into inferior vena cava. This patient had a huge HCC in the right hepatic lobe and with invasion into inferior vena cava. Then we administered the NUFP treatment. Then the old tumor disappeared and he survived for 4 years after NUFP treatment. Summary, in patients with ACC, local region treatment using HAIC, especially NUFP regimen, was superior to sorafenib. The presence of major PVTT and presence of extrahepatic spread was a poor prognostic factor. Child-Pugh score of 5 and choosing NUFP was a better prognostic factor. NUFP therapy was superior to sorafenib for ACC with macrovascular invasion, regardless of the presence of extrahepatic spread. Conclusion, in the era of chemodiversity, powerful local regional treatments such as NUFP could be useful to control hepatic regions that could lead to prolongation of patient survival. Thank you for your attention.
Thank you for your interesting presentation on the HAIC therapy for advanced ACC. Is there any questions or comments from our website? Okay, I agree that.
Thank you for excellent presentation. I'm Shinji To from Kyushu University. I'd like to ask you one question. In this series, conversion surgery included after HAIC in this?
Yes, thank you very much. As you say, the conversion surgery is very important in the treatment of NUFP. Actually, today I did not show the therapeutic response of NUFP, but the therapeutic objective response rate was 70% and complete response rate was 30%. Then this 30% includes the conversion surgery cases. Then mainly for example, after PR treated partial response case in NUFP or CR case, we try to administer the hepatic resection. Then cancer-free will be achieved.
And is there conversion case after sorafenib?
There is no such cases. So that is very important. So now we have atezolizumab, bevacizumab. Slightly this kind of rate is increasing. However, but the NUFP is still high, I think.
Thank you.
Thank you for excellent talk. I'm Isayama from Juntendo University. So we also are performing the NUFP, both HCC and intrahepatic cholangiocarcinoma. So, and from my impression, it is totally very long time required to perform the NUFP. So my impression is Lipiodol is very effective to suppress tumor.
Yeah.
So when this treatment prolong the infusion time, so arterially. So then I think this treatment can shorten. How do you think about the regimen of the treatment schedule?
About the treatment schedule.
Yeah.
Yeah. So the mechanism of the therapeutic mechanism of anti-tumor mechanism of NUFP is there is three. First is, as you say, the Lipiodol effect. Lipiodol effect has some mild embolization effect.
Yes.
And second is we suspend with Lipiodol and cisplatin. If we use this suspension, the cisplatin will gradually cisplatin will be gradually secreted from the Lipiodol. And the third is biochemical modulation from the to the 5FU. So the cisplatin and so yes. Then so firstly we inject the NUFP cisplatin with Lipiodol. After that, 3 to 5 days 5FU injection. Maybe we can shorten from 3 to 1 or 2 days, and in one session. Then what do you want to ask about that? I mean, the treatment schedule to the, for example, hepatic resection. I mean, you have a question.
My question is, if you shorten the infusion time, but tumor effect is the same or down?
Actually, sometimes I tried a shortened version of 5FU injection, but there was no significant difference between the, for example, 3 to 4 days or 1 or 2 days. But those will be a little bit limited. I mean, 3 to 4 days, we use more than 1,000 milligram 5FU. But if we use 1 to 2 days, we use 500 to 7,500 milligram of 5FU. But in my expression, there was no such a big difference between them.
Okay, thank you very much.
Thank you very much.
I agree that powerful effect on the MVI positive SCC. But how about the X-ray hepatic metastasis? The effect of the X-ray hepatic metastasis?
Yeah, actually, when we use Lipiodol with Lipiodol suspended with cisplatin suspended with Lipiodol in the metastatic site, there was no such effects. But recently, I use a new device. This device can make a good emulsion with cisplatin and Lipiodol. If we use this in my case, after injection of NUFP, the metastatic site was also effective because I checked the serum level of cisplatin that gradually increased compared with the suspension.
Yeah,
Yeah.
very interesting.
Thank you very much.
Yeah, thank you for a good presentation.
The last talk of this session is Dr. Naoki Hashimoto from Sendai City Hospital, Department ER. Effect of this distal splenorenal shunt plus splenopancreatic disconnection on glucose and amino acid metabolism. And Dr. Hashimoto, please go start your lecture.
Thank you. Thank you. DSRS is aimed at decompressing esophageal varices via distal splenorenal shunt, at the same time ligating left gastric, gastroepiploic, and umbilical vein. In the long-term follow-up, the loss of shunt selectivity was observed. Warren reported splenopancreatic disconnection, SPD, to prevent splenic collateral from stealing portal venous blood. This is a distal splenorenal shunt. Ligation of the left gastric vein, gastroepiploic, and umbilical vein, splenorenal shunt. But long time the follow-up angiography, loss of shunt selectivity. This portal malcirculation is most commonly through pancreas. Therefore, the Warren splenopancreatic disconnection. In the long-term follow-up, the loss of shunt selectivity was observed. Therefore, they reported splenopancreatic disconnection to prevent splenic collateral from stealing portal venous blood. Splenic vein was dissected totally free of the pancreas. Therefore, we used the 10 patients with recurrent esophageal varices, secondary portal hypertension before and after DSRS plus SPD. IVGT 20 gram glucose 2 minutes, 0, 3, 5, 10, 20, 36 BS, and insulin check. Blood sugar level, open circle before, cross circle after shunt. Blood sugar level, there is no difference, but the glucose level 3 minutes, 5 minutes, before shunt slightly higher. Glucose disappearance rate, K equal 0.693 per T nibbon T half time, K glucose before shunt 2.3 plus minus 0.2, after shunt 2.5 plus minus 0.2, slightly better after shunt. Fisher ratio also the before shunt 1.53 plus minus 0.2, after shunt 2.0 plus minus 0.2. Therefore, the shunt DSRS plus SPD shunt selectivity, therefore the K glucose and Fisher ratio are better compared to before shunt. IRI, next IRI level. Before shunt, after shunt, IRI, before shunt much higher compared to after shunt. IRI behavior tends to be the lower after operation at the level of the peripheral blood. This appears to be due to the fact liver is the major site of the degradation of insulin. Because the portal systemic shunt decreased as a result of devascularization of the collateral circulation by the selective shunt, thereby causing the IRI behavior to be lowered after shunt. Conclusion, DSRS plus SPD maintain the selectivity of the shunt and had favorable effect on glucose and amino acid metabolism. Thank you.
Thank you, Dr. Hashimoto. Now open for discussion. Is there any question and comments? Dr. Hashimoto, I know the Inoxi Warren shunt.
Yes, yes.
But now young doctors don't know the Inoxi Warren shunt because this is a very classical operation. Do you operate on this kind of Warren Inoxi now?
Now recently, Nihon Ilai, Professor Yoshida, performed the DSRS shunt. Now in Japan, from the esophageal varicose treatment, EVL and sclerotherapy, and sometimes splenorenal shunt occlusion. Sometimes Europe and America chips. Now not so popular in selective distal splenorenal shunt, but the Nihon University Professor Yoshida performed the wonderful distal splenorenal shunt. But we sometimes the DSRS postoperative encephalopathy. Therefore, the SPD perform. But in case of SPD, sometimes we experience pancreatitis. Perform the splenic from pancreas to splenic vein ligation. Therefore, the maneuver and some case of pancreatitis. Now, from the worldwide, DSRS not so popular now. In Japan, the surgical treatment HACC is for the uncontrollable gastric varices only. From my impression, the DSRS is a good operation.
Yeah. I completely agree with you, but in my institute, Tohoku University, maybe 30 years ago, the last Inoxi chance. So, okay, is there any question or comment? Okay, Dr. Hashimoto, thank you for your excellent speech. Now, we'd like to close this session, and thank you for coming to Sendai. Thank you.
Thank you very much, chairs and lectures.